Good morning, everyone. It's good to be here. It's been a long time since I've attended a gym nurse conference back in the old days of coming into Toronto, so it's good to see some old faces and see some new ones here as well. Today, I'm just going to be sharing the findings from this is a very Coles Notes version of it, but a very large evaluation that we undertook evaluating our GEM nurse program in the Central East region of Ontario. My background, I'm since about 2013 been the Director of Research and Evaluation for Seniors Care Network and the regional manager for the regional GEM program. We did have a funded program through the former Central East LHIN, now Ontario Health. I have no conflicts of interest to declare, but I do want to acknowledge our former evaluation analyst, Terry Lee, who was the lead on this work, and I believe is now at UHN in Toronto. And you can see the fantastic work in the full report on our website, which I'll leave a link for at the end. So our program in the Central East consists of advanced practice nurses in the emergency department who deliver comprehensive emergency geriatric assessment and interventions for older adults. They also connect older adults and care partners to community supports, and there was explicitly a role for fostering collaboration and building capacity in geriatrics within the hospital and in some cases outside in the community. It is our oldest funded regional SGS program in the Central East, first funded through provincial funding in 2003 for a nurse practitioner at Scarborough Centenary, and then in 2009, an additional 8 full-time equivalent gerontological nurse specialists directly by the former Central East LHIN, now Ontario Health East. That being said, there are more GEM nurses in our region than what was initially funded, thanks to efforts to the hospitals who have self-funded roles, as well as Ontario Health East, who's funded additional roles through other mechanisms. Because this was the oldest program, SGS program, we wanted to really look and get a handle on the outcomes of the role of GEM. We've struggled with grappling with this question since the original pilot funding in 2003. There's been evaluations done in the past, and we still have this discomfort around actually putting monetary values to the outcomes, which I completely understand because it's such a complicated, complex process and situation. So we engaged in a very lengthy consultation process with our GEM nurses and the hospitals following the CDC evaluation approach, which I'd love to point you to those resources. They used to have a fantastic library of evaluation resources, but I think it's been archived. But I still follow this approach to this day. And we use the Phillips ROI methodology which really looks at 6 different evaluative dimensions. And we selected a variety of different methods to collect prospectively and retrospectively data to understand those different elements. Our key objective was to establish a link between the GEM program inputs and the ultimate impacts, and then to convert the tangible GEM program impacts into a return on investment value. And we were really hoping that the quantifiable GEM program benefits were greater than the program costs, both in terms of unanticipated outcomes, but also the actual funded costs of the program. But we also wanted to look at the intangible benefits. So these are the things we've talked about for 20 years about the value of GEM, what we know intuitively is the value of GEM, but it's not really conducive to putting a monetary value to it. So between 2023 and 2024, we engaged in this process. At the first dimension, this was based on GEM nurse interviews with our GEM nurses. We found that the program consistently operates weekdays for approximately 8 hours a day. There is variation depending on site. Some sites work a little bit longer. Some have some modified models with weekend coverage and evening coverage. The majority of time is allocated to clinical work. So, despite the early days of the GEM development of the GEM nurse program across the province, which the estimated uh, time spent was 80% clinical and 20% capacity building, we do find that that's over time that's shifted and it's primarily clinical work to meet the need. All GEMs are in our region were certified specialists in gerontology through the Canadian Nursing Association, but they'd also accumulated additional training and healthcare experience with geriatric populations. And the majority of the GEMs were master's prepared or were in the process of completing a master's degree. At the program reaction level, we found there was good perception of the program overall, and this was based on a combination of GEM nurse interview responses and an ED staff survey that was conducted using a 5-point Likert scale based on level of agreement. There was strong buy-in from the GEM nurses, which is good to see. We like to see that there's the GEMs themselves see value in the work they do. With both responses from the ED staff and GEMs, we found there was a belief that the program makes a difference in the patient's care, contributes to safe discharge and decreased length of stay for ED patients, reduces unnecessary ALC occupancy after admission for those who are admitted, and was of a high quality. In terms of confidence in knowledge and skills of GEM and the GEM program, in general, both GEMs and ED staff were confident that they possessed the knowledge and skills to drive the program forward and deliver on its success. The GEMs found that they had the requisite knowledge and skills to, perform targeted geriatric assessments, advocate for appropriate disposition when it was warranted, and effectively refer patients to appropriate community-based services when it was warranted. The majority also found that they had the skills and abilities to effectively conduct follow-up with patients. So that's a key component in the role. In terms of ED staff confidence, we found that the majority of staff indicated that they had very high ratings of their confidence in their ability to appropriately refer to the GEM nurse, which is, something we always question in geriatrics is when we're getting appropriate referrals. But in general, they felt they had the skills for it. In terms of application, we wanted to understand if this was based on both interview data and retrospective analysis of historical GEM program data, including the metrics we collect. So this is just a snapshot of some of the elements that we looked at. We found that GEMs were providing consistently geriatric assessments and interventions to older adults year round, and we have data supporting this going back to 2012, I believe. And GEMs frequently connected older adults to community services and supports, majority of which were community-based home services and community support services, but also alternate specialized geriatric services in different settings. In terms of the intangible benefits, so those are the outcomes that we can't necessarily assign a monetary value to. This was based on input directly from the GEM clinicians who possess subject matter expertise about the program. So we looked at those more experienced GEM nurses who'd sort of been around for a while. And many intangible benefits were described as part of those interview process. Some key ones is that they felt that the gerontologic knowledge in the ED and hospital staff was increased as a consequence of their presence in the ED and their work that they did in the ED. And they also felt that their presence improved patient satisfaction with the ED care. There's a challenge with these benefits. So these aren't included within the ROI values. So we'll move into more of the tangible ones. So these are the ones that we can ascribe monetary value to and use to do an ROI calculation. So we looked at three different costing scenarios and different measures. These are the ones that we included in the ROI calculation that I'll present in a moment. This was the more conservative estimation. We did those other two costing scenarios had a much greater ROI return. Um, but we felt this was more accurate to what we were based on what the GEMs were saying, what the hospitals were saying, and the historical experience with the program. So, in terms of the benefits, so these are the positive outcomes of the program. Using a case control, we used retrospectively collected data from patient charts with the assistance of decision support directors of care and the GEM nurses themselves, and we constructed a case control group that accurately met what would be an equivalent of a GEM nurse patient who hadn't been seen. And then we compared that to prospectively collected information that the GEM nurses gathered about GEM patients and what their ultimate these different indicators looked like. So we found based on that that comparing those two groups, there was a decrease in hospital admissions in the inpatient and in alternate levels of care within the year. We found that there was a decrease in inpatient length of stay after admission. So these are GEM patients who've been admitted. A decrease in the rate of becoming ALC after admission within 30 days. And we also found, although we didn't include it in here, that the GEM nurse assessment and care led to increased linkages with specialized geriatric services and community programs that were appropriate for their needs. In terms of the costs, we found that the patients that were seen by GEM nurses and assessed, they did have a longer ED length of stay, which for the GEMs around the table, we know that's intuitively that's how it works. And we did find that there was an increase in ED revisits within 30 days from the initial. And we've done evaluations on that metric in the past many times, and we can go into that another time of why that happens. But effectively, these were the differential for our costs and our benefits. What am I doing for time? In terms, then we converted it into an ROI value. So these established monetary rates, and I won't go through all the math. You can see there's maths here, lots of maths. But through this, we were able to establish standardized rates for each of the different indicators, and then extrapolate that for a year. So we'd get an annual cost or benefit per year. So those five indicators you've seen on the previous, but also the estimated cost of the GEM nurse program itself. So the 130,000 per site. That is extremely low, but that was based on what was initially funded in 2009. So we know GEM nurses cost a little bit more than that in the care itself. And then using that, effectively, we calculated the return on investment for the program it's a basic costing analysis that they use for ROI, but also in others. It's basically the program benefits divided by the program costs and multiplied by 100 to get you a percent. And we found based on this conservative costing scenario, a positive ROI value of 354%, which was fantastic because we were hoping for maybe a 1 or 2%, which is sometimes typical with ROI conversions. But effectively, what that means is that taking into account all of the unanticipated outcomes and costs and the benefits of the program, the monetary savings were greater than the program costs themselves. And that was equivalent to approximately $1.13 million in savings per year per GEM nurse. So the next steps with this is we use this information and we provided it back to the different hospitals, to OH, and we've distributed it more widely. I've been pleased to see that there's been additional roles have been funded for GEM Nurse. We certainly have more. Many, thankfully, to the hospitals themselves self-funding these roles. And then our next steps, this evaluation gives us a lot of really detailed information aside from just the lovely ROI value we can use to advocate for further funding, and to demonstrate the effectiveness of the role with different stakeholders. It gives us additional information we can use for the purposes of quality improvement. And because of that back and forth that happens through the development of these different measures and how we collect things, and we were able to uncover a few different variations in processes that we could think about, and look for quality improvement opportunities. And then our next steps as Seniors Care Network, as the regional geriatric program, is we're applying the same methodology to other SGS programs in our region, including the Durham Primary Care Collaborative Memory Clinics and our large outpatient community-based geriatric assessment and intervention network team. So those are in progress. And if you'd like to see those reports in full, please feel free to take a peek at our website. And they're all listed there for you. And if you have any questions, please reach out. I'd also just like to say Happy Nursing Week, in particular to all of the GEM nurses in my area, the two Michelles, Carmela, Moen, Jen, Karen, Rachel, Terry, Christina, and Kathy. So thank you very much.
Thank you, Stacey. Excellent. I've not seen a presentation of the return on investment value, so I think it's something to take note of. Do take some time to download the resource. It's really interesting to see how you work through thinking about return on investment, and I think Seniors Care Network has done a fantastic job. So thank you again for sharing those insights. I think we know that that GEM nurses add value, and you have helped to prove the point. At $1.13 million per GEM nurse, isn't that fantastic? So do take a look. And thank you for our previous speakers who continue to answer questions in the chat. Stacey, if you got a couple minutes to